Hi, this is Crystal Lim giving a presentation on special populations focusing on mental health issues. I'll be talking about 5 different populations: the elderly, geriatrics, prenatal, lactation, postpartum, pediatric adolescents, LGBTQ, and immigrant workers. The first population I'm going to be talking about is the elderly and geriatrics. Globally, the population is aging rapidly. Between 2015 and 2050, the proportion of the world's population over 60 years old will double from 12% to 22%. Mental health and well-being are just as important now as they are at any other time in age, and approximately 15% of adults who are aged 60 and over will suffer from a mental disorder. Common mental health concerns in this population are dementia, Alzheimer's, depression, anxiety. Assessment and screening for this population for each disorder. For dementia, there is no sufficient evidence that recommends for or against routine screening for dementia in older adults. Patients with cognitive complaints or family members that come in with family complaints for a family member can undergo a careful mental examination. Screening tools to be used can be the mini mental state examination and an extended mental status examination if dementia is suspected. For depression, depression is not a consequence of normal aging. Later in life, depression remains underdiagnosed and inadequately treated. Screening tools are the PHQ, PHQ-9, the Geriatric Depression Scale, and the Cornell Scale for depression and dementia. For anxiety, late onset GAD, generalized anxiety disorder, is usually associated with certain demographics, clinical environment, and risk factors, and it's a very common diagnosis in the elderly. Screening tools can be the GAD-7 and the Penn State Worry Questionnaire. Treatment plan for these conditions in the elderly. For dementia, first you need to make sure that we get an accurate diagnosis of what type of dementia and then a referral to a specialist if needed. We need to assess the risk for harm and ensure safety. Avoid any adverse drug effects from medication they may be taking. Polypharmacy and drugs that exacerbate the impairment. Can do a cholinesterase inhibitor or a memetime. They're the only current available symptomatic medications for cognitive and global functioning in patients with dementia. Depression, you want to assess for any suicide ideations or plans. Consider any other medical conditions that might be causing depressive symptoms. First-line treatment for depression consists of psychotherapy and medication. SSRIs are considered first-line for treatment of depression in older adults. It's tolerated better, easy to use, and generally safe, and especially in overdose. And SSRIs are considered the best safety profile for the elderly, and those would be citalopram, escitalopram, and sertraline. For anxiety, cognitive behavioral therapy, exercise, stress management, and avoid triggers. Buspirone is an anti-anxiety drug that has been shown to be effective in older adults. Benzodiazepines are effective but should be prescribed carefully or not at all to older adults because of risk of memory impairment, unsteadiness, and falls. Antidepressants can be used as well. Beta blockers also can be used to help. Next group is the prenatal, lactation, postpartum. I'm going to be focusing most on the postpartum population. Postpartum is the first 12 months after birth. Postpartum mood disorders are common, and they're increased in the postpartum period for any reoccurrence of psychiatric illness, including mood, anxiety, and psychotic disorders. The most common ones are postpartum blues and depression, post-traumatic stress disorder, and postpartum psychosis. The assessment and screening for postpartum depression, you need to define if it's either postpartum blues or postpartum depression. The onset for postpartum blues is usually 1 to 3 days after delivery and will resolve in 1 to 2 weeks, and it's self-limiting. Depressive symptoms last longer for at least 2 weeks and a minimum of the 5 symptoms of dysphoria, insomnia, fatigue, impaired concentration, sadness, irritability, anxiety, mood liability. And screening tools to be used for that are the 10-item Edinburgh Postnatal Depression Scale, or the PHQ-9. Postpartum psychosis is rare. It occurs in 1 to 2 per 1,000 births. It is less common, but it is potentially life-threatening. Their screening just needs to be done at appointments, especially for patients who have a history of bipolar, mania, hypomania, psychotic depression or psychotic disorder, suicide, or any family history of those things as well. And patients should just be educated and closely monitored. Treatment plans for postpartum depression need to see if the medication risks outweigh the risk of potential risk to the infant. Most SSRIs are usually low and generally considered compatible with breastfeeding a healthy full-term infant. If someone's being treated with an antidepressant during pregnancy, it's preferable to stay on that one for breastfeeding. Paroxetine and sertraline usually are used first because they have low effects for the infants. You can also add in therapy, exercise, peer support, and counseling. Postpartum psychosis, the number one thing is for safety. It's a medical emergency. Most patients probably need to be admitted to a psych hospital or emergency room, and it's typically treated with antipsychotic medication and mood stabilizers. The next group is pediatrics and adolescents. This population, mental disorders are described as serious changes in the way the children typically learn, behave, or handle their emotions, causing distress and problems getting through the day. About 10% of children and young people have mental health problems that so significant and affects their day-to-day life. Due to the COVID-19 pandemic, there has been an increase in anxiety, depression, sleep appetite in children and adolescents. Common mental health concerns for this group are ADHD, anxiety, behavior problems, depression. For the adolescent group, there's also substance abuse and suicide. Assessment and screening in the pediatric and adolescent population for ADHD. These symptoms affect cognitive, academic, and behavioral, emotional, and social functioning in more than one setting: in the home, school, after school, sports. It's a disorder that have symptoms of hyperactivity, impulsivity, and inattention. There's different screening tools to be used for different ages. There's the behavioral assessment system for children. A popular one that's used a lot is the Vanderbilt Assessment Scale and the Conners Comprehensive Behavior Rating Scale. Depression. In the pediatric populations, they may lack emotional and cognitive ability to correctly identify and organize their emotional experiences, and depressive disorders may express themselves with an irritable mood or anger. Bright Futures AAP suggests universal screening for depression annually for ages 12 to 17 or younger with any risk factors using the PHQ-2. You can also use the PHQ-9 modified for teen, Kushner Adolescent Depression Scale, and the Columbian Depression Scale. Substance abuse is common in the adolescent group and is increasing. Binge drinking is also increasing, and there's deaths associated with that each year. The AAP recommends screening at age 11 for the use of alcohol, tobacco, and drugs annually. You can use the CRAFT screen or the NIAAA screening. You can also do labs for toxicology or drug screens. Treatment plan for ADHD usually involves stimulant medication combined with behavioral therapy. Common medications are Focalin, Adderall, Concerta, Vyvanse. Patients should be monitored regularly for adherence to the treatment plan and effects from the therapy in response to the therapy. For depression, safety is the number one priority. Want to make sure that there's no signs of suicidal ideation. Collaborate with the family. The patient and the school might be helpful, and depending on severity, you can do combination or monotherapy, either with medication or just therapy or both. And children and adolescents with acute depressive disorders, the first line treatment is the fluoxetine. For substance abuse, there's a lot of things that can be done. The primary goal, of course, is to have abstinence from substance use, Mild cases can be used with counseling and group therapy. For severe and moderate cases, medically supervised withdrawal and maintenance treatment. Naloxone can be used in ages 16 and up for substance abuse disorder. And then just make sure that the adolescents are in counseling and group therapy. The next group is LGBTQ. LGBTQ may be associated with the increased risk for mental health problems such as suicide and self-harm, increased stress, anxiety, depression, and then that can contribute to long-term social and health outcomes. Some of the most common mental health conditions in this group are anxiety, depression, suicide, self-harm, substance abuse, and PTSD. I'm going to focus on the suicide risk part of this for the LGBTQ population. There's not actual rates available to see how many suicides have taken place in this population because gender identity and sexual orientation are not reported in the death record. But there has been a reported that 2 to 3-fold increased risk for suicide attempts in this population compared to other ones. And among transgendered adults, the lifetime prevalence of suicide attempts is 40%. And there has been increased higher rates of suicide thoughts and attempts among adolescents and young adults also identifying as a sexual minority. There is no specific LGBTQ screening mechanisms for suicide. There's no universal agreement on the definition or utility of either suicide screening or assessment. If there is suicide suspected, you can do the Columbia Suicide Severity Rating Scale, and then also always screen with the PHQ-9 for depression. Look for warning and risk signs for suicide, including hopelessness, history of suicide attempts, co-occurring mental health and substance use disorders, history of physical or mental abuse, lack of social support and access to firearms or other lethal means. Treatment plan for suicide risk. Of course, the number one priority is making sure that the patient is safe, medical stabilization if needed, have a safety plan, risk reduction, removal of access to lethal means, treat any underlying mental health disorders, provide that non-biased compassionate care, and empower assertive communication, give lots of resources to the patient that they might need, also connect with other LGBTQ affirming counseling, therapy, medical care, and specific resources. Next group is the immigrant and migrant workers. There are 44.9 million immigrants that live in the U.S. in 2019. 32% do not speak English well, and 28% live in linguistic isolation. Immigrants experience more problems in depression, anxiety, and somatic disorders related to the migration process and stress suffered. Immigrants face unique stressors because of that experience. Common health conditions in this population are anxiety, depression, PTSD, feelings of marginality, and alienation. Anxiety in this group, there's a high prevalence of mental health issues in refugees, including depression, anxiety, post-traumatic stress. Assessing mental health is challenging and made even more difficult with language barriers, perceptions, conceptions of mental health illness in other cultures, lack of standardized screening instruments for different populations. The number one thing would be to use a language line or a translator to communicate with these patients in their language. Screening tools can be the GAD-7 item test or the Penn State Worry Questionnaire. Management plan would include to remove barriers, and that would also include using a language line. That would be the number one thing. Also for anxiety specific is to treat also for the patient preference and the extent of the distress. The main goal is reducing symptoms of anxiety and improving functioning. You can do therapy or medication or both together. Medication for anxiety can be SSRIs or SNRIs. Those are first-line treatment for generalized anxiety disorder. There's a Brightside Foundation, and it's a nonprofit formed to help immigrants support those who are entering the United States. And that would be a really good resource to share just to help them have resources to transition to the new company to decrease that anxiety. Thank you so much for listening to my presentation, and y'all have a good day. Here's all the resources. and references. There's a lot of them.